from the Northwest Regional Telehealth Resource Center. I'm the program director here, and today we're, Marlene, I apologize, I've lost the intro card too because that's on my other computer. But today we're having one of our monthly webinars, and we're talking with Marlene Maheu, PhD, on best practices for the successful legal and ethical telemental health. And I apologize again for the equipment failures we've had here and not being prepared as I should be. But Marlene, I'll just go ahead and say thank you for coming in. And if you want to give a little bit of your background as you start up, that would be just great. Okay. Thank you.
Thank you. Well, I'm glad that we actually are having the event, so that's wonderful. I am a psychologist by training, and I am the executive director of the Telemental Health Institute. My team and I have written a number of textbooks about telemental health and telehealth, e-health, telemedicine, and we are focused right now on bringing professional training to people, through professionals through the internet. And we have a website at telehealth.org. So any of you that want to pop over there and take a look while we're talking, you get a better sense of what I'm doing. My main focus since 1994 has been how can mental health practitioners work through the internet, work through technology in general, but mainly through the internet to deliver reputable practice and manage their risk. And it's only been in the last few years that we actually have adequate video through the internet. But that is perfect timing for us because we've taken our books and brought them online for professional training, and we offer a number of functions there, which my speaking to different groups about best practices tends to address a lot of the concerns that they are running into as they get things set up. So I will invite you today, if you want to put your Q&A, some questions, please feel free to ask questions as I speak, because I'll touch on a number of different areas. And happy to stop at any point and answer some questions. You don't have to wait till the end. First off, I just want to be clear. I'm a psychologist. I'm not an attorney. I'm not a physician. I'm not a marketing and informational technology professional. And what I try to do is just bring educational information to people to help them understand the issues and alert them to some of the more important things about what's happening today with the news, with the different policy changes. I'm very active with policy change over at the American Telemedicine Association, and I'm working right now with them on their Internet Guideline Committee. They're calling it Desktop, and it's kind of a long name, but it's come up with guidelines for how to practice in mental health. So I'm with the Telemental Health SIG over there. And I'm doing a number of things at the American Psychological Association on the same line, so I'm informed about these issues, but my goal is only educational. And bottom line, what's happening is we're retooling. So we as a nation, we as a world are retooling. We're using technology more and more, and we will continue to do that. So it's just moving faster and faster, and the price points are coming down. I show this particular slide because what I'm trying to indicate here is that we fall in one little line of a very big picture of what's going on in healthcare, not only in the United States, but worldwide. And communications, being the internet and things that are based in communications, it's just a very small piece of it. But the movement is very big, and it is in not only information technology, but in also biotechnology and nanotechnology. And then we have areas that intercept in the middle that include things like nano devices and sensors, and then biosensors and biochips that do impact behavior. And we're seeing more of this come through the mHealth world, where there are sensors that we can put on ourselves, and they get mediated by the device that we're dealing with, and information gets transmitted or stored or analyzed by the device. So there's a lot happening that's just not in the realm for most of us, but nonetheless it impacts us. So that's one thing I'm trying to show with that slide. Another thing here is that the terminology we're using is in rapid flux. When I first wrote my textbooks, we were talking about behavioral telehealth. That was a main term, but there were a number of other terms that were floating around at the time. Telepsychology, online counseling, online therapy. Now we have mHealth, e-health, telehealth was a big one. Of course, telemedicine was the first one. And now the sort of the catch-all term in the literature is telemental health. So that's where we call ourselves the Telemental Health Institute because of that. And as you look at the literature, you'll see there's more TMH, which stands for Telemental Health, information coming out. It involves a number of different modalities. It involves lots of things on the internet, from blogging all the way down to virtual private networks and cloud-based video. So there's no individual area that is alone or unique. It's mostly, the literature is mostly focused on video, however. It's not on email, although a fair number of clinicians are using email. The literature does not support a lot of that. There's a lot of experimentation going on in email and chat, text messaging. There's just not a lot of literature to support its use. Most of the literature is about video. So that's what we focus on at the Institute primarily, although we have courses about texting and those kinds of things too. But our main focus is the literature and what has been shown effective at using video-based interfaces, as well as smaller video through pocket-held devices. This is a Samsung Galaxy, and it's been adapted for stroke patients. This is one of my consulting clients that let me use this picture. They develop devices for stroke because it fits in the pocket. Nowadays, what we're seeing is the iPad will have a mini that too will fit into the lab coat pocket. And you can just tell these organizations are targeting mental health folks more and more. What we're really wanting to as clinicians, what we're really trying to get across to folks is that the primary focus is not the device, though. The primary focus is what we're delivering, which is the service. For us, it's mental health care. It just so happens that the tube that is carrying all of that changes. There are different types of devices that do pretty much the same thing. Now that we have HIPAA compatible devices, then some have whiteboards, some don't, but the device itself is not really the main focus. It's mostly what do we do with that device. And so we see that there are studies that have come through, and they again don't really focus on the device, but they do talk a lot about the actual care, the service that's delivered. And so we're seeing that there's a fair amount of information coming through, and this has been coming through steadily for about 5 decades now, since 1959, the first telepsychiatric consult. The data shows that it is effective. It is now paid for by Medicare and Medicaid, although those reimbursement rates are steadily declining, but there's Medicare and Medicaid reimbursement in certain environments. Outcomes are relatively comparable to face-to-face care, especially for follow-up care. That initial intake is still up in the air because some states require that you have an in-person assessment for intake, and then the care gets transferred for follow-up through video conferencing. It's also, the body of literature for supervision is quite robust. There are a lot of studies that show it's quite effective and safe, and that trainees can be supervised, and that in some ways the service can actually be improved rather than us always thinking it's going to be diminished remotely. If you think about the person who is treating somebody for agoraphobia, or someone who's being treated for fear of elevators or fear of flying, you can actually be with the person live using one of those smaller devices and have it be HIPAA compliant, of course, because a lot of the iPhone's materials or devices are not HIPAA compliant. But if you have some that have the added precautions put on them, then you can be present with them wherever the patient needs to be, and you can help walk them through things. And we're going to be seeing more and more and more of that. And we have a fairly robust bibliography about that at our website, which once again is telehealth.org/bibliography. You'll see we have over 1,000 references, mostly in mental health there, Telemental Health, and it's searchable, so you can look it up by term or by author, and you can get the actual citation. The main thing that I try to show when I do talk about video conferencing, though, is that it's not the same as Skype, and I know that most people on this call wouldn't be aware of these issues, but I'll just cover it too. Skype has its peculiarities, and one of them is that they don't have an audit trail. So without an audit trail, we can't be saying we're HIPAA compliant or that that they are HIPAA compatible. So it's a bit of a challenge to use Skype right now, but I have every reason to believe that Microsoft will get that organized properly and they'll be able to use it in the future. It's just right now they're not compliant. Oh, they're not compatible. We're the ones that need to be compliant. They need to be compatible if we want to use them. So there are many benefits to traditional video-based telehealth, and that is the number one item, of course, is increased patient-client satisfaction. We've seen this across the board, and we're not really sure what that's about. Is it because they really feel connected, or is it because they don't have to drive that 300 miles to come and see a clinician and take care of their son? It's tough to say right now, and some researchers are trying to ferret those things out, but we do see that there are a number of other benefits that are dependent on that. Decreased travel time, which of course would add to satisfaction, decreased travel expense, and decreased child and elder care costs. If you are taking care of children in the home or an elderly parent, and you have to leave for a day to take somebody down for an appointment, then somebody has to take care of all that, and it costs money, so those costs come down. Also, we can access underserved populations. More rural folks get served. What happens with them is if they get properly assessed and treated early on in the trajectory of their disorder, then they cost the system less money, and so there's a fair amount of focus on dollars saved with earlier intervention. There's also improved accessibility to specialists. So you get somebody over to the right type of care, then that will cost the system less money as well. Reduce emergency costs for the same reason. People get an intervention earlier on. Faster decision-making time. When there is an emergency, then somebody can go right to somebody who knows exactly what may be best in that situation. Increased productivity on the part of professionals. Decreased lost wages on the part of the client, the patient. They don't have to take a day off of work to go have a mental health appointment. And just overall, because things are automated, there's improved operational efficiency. So you see there are many different categories, and there are more. These are just kind of the main ones that we can easily point to. The thing that most people get stumped by is what legal ethical rules apply, and it's pretty simple when you stop and think about it. They all apply. It's just that for some professions they've not been interpreted for people, but when you stop and take a look at what an ethical code says and you talk with other people that are in the field, it's easy enough to extrapolate out. Some groups have or are in the process of coming up with specific guidelines for their membership. So the American Telemedicine Association came up with 2 guidelines that were very well done. They were in 2009. One was just a general best practices, and another one was a guideline for video conferencing. The thing is that they excluded the internet in that guideline for video conferencing, although many of the same things apply, but they did not have a robust enough literature at that time to look at that. So now we have a more robust literature, and I'm in on that group that's coming up with guidelines for the American Telemedicine Association. There's also a group right now coming up with guidelines at the American Psychological Association, and they just opened them up for comment in July, and they close tomorrow. So if you're a psychologist or you know psychologists that would want to have input on this, they need to go to the American Psychological Association website, which is apa.org, and look for the telepsychology guidelines and read them carefully, because frankly they are, in my opinion, overly restrictive and ask clinicians to do things that are physically impossible, which is to know all of, for example, all of the risk factors in a patient's environment. Well, we don't know about that for a patient face-to-face, never mind someone who's at the other end of the state. So very difficult to implement some of the guidelines as they're written, so they definitely need commentary. And in our newsletter, we have a newsletter at the Institute that we release every week. This week we released a newsletter that talked about that. And I'd be happy to share it with you if any of you are interested in it. We have a newsletter. We went through the psychology guidelines and extracted the words that we thought were going to be rather difficult for people to be following, because it's just basically physically impossible to do that. So the risk management just involves following legal and ethical rules. The legal rules are the same thing. They are pretty much state-based, and many states do not have an exception to the rule for telehealth or telemental health. You just have to follow the general rules of practice, which is maintain confidentiality, keep patient notes, the standard things that we'd expect. Have informed consent. Many states have a requirement for informed consent. As I was mentioning earlier, some states have a requirement for in-person assessment. 38 states happen to have that requirement for in-person assessment. If you're not in the military, if you are just a regular practitioner or a hospital system, you need to have that in-person assessment for writing prescriptions. Some states have a special law just for mental health practitioners that are not licensed to write prescriptions, so psychologists, counselors, social workers, but many states do not. If a state does not have a special code for a particular discipline, then it normally defaults to the medical code. So it's reasonable to assume that many states have that law in place. It's just not something that people talk about. They don't realize that perhaps they need to be having an in-person assessment before they deliver telemental health care. So the thing to do is to go read the state code. If you try to contact some of these state boards, they don't necessarily, they're not necessarily jiffy on the spot and answer you that same day, if at all. So most states do have their legal code up on the website, and if you read it, it's not that complex. I know for California, our state code is there. It's called the Business and Professions Code, and we need to go in there under psychology, and it states everything we have to do. Most of the time, it will not stipulate these kinds of things, but it will have a code, and it will say something like the professional needs to adhere all of the code sections, and they link a code number. And if you click that, it reverts on over to the medical code. So you see a lot of times that medical code is something that mental health practitioners need to be aware of and need to be abiding by, because it is literally referenced in whatever other group of laws that relate to specific disciplines like psychology or counseling or social work. The bottom line on all of this, both the legal and the ethical code, is that safety comes first. And I bring this to the forefront here because some clinicians that I've spoken with, many of them that come train with us at the Institute, have the mindset that there are many needy people in the world and the number one priority is to service them. And I just think it's important to have a discussion about it. I mean, everybody's licensed and you can go service who you feel is appropriate, but when you look at what the federal government has done, they've not said we're going to service anybody out there who needs it. They have wired up hospitals to clinics. They make sure those systems are in place. They all use HIPAA compliant technology. People have to be licensed. They have to be credentialed by the hospitals. Some of those credentialing rules are loosening up, but still, a lot of things have been in place. It hasn't been this willy-nilly, oh, let's just jump on the internet and talk to anybody who needs help. It's been a very systematic rollout of the infrastructure and then the practitioners being allowed to go and service people using the infrastructure that's in place. So I think one of the problems we're having is that the technology is running ahead of the legal and ethical groups, and so they're not able to keep on top of interpreting this for every new technology that comes out. So we've got practitioners that run out there ahead of the law because they can use the internet. And even if they use a HIPAA compliant service, maybe they're not following good legal practice, which is practice in your state, do a proper intake, do a full assessment, refer to people as needed, have contact with other clinicians, document, all the things we have to do as part of professional practice. So I'm going to take some of these one by one and we'll go through them. And here I'm just going to be quoting either some state law in my state or an ethics code or two that I know from different groups because I've worked with them. So the APA ethics code talks about informed consent. You have to properly document written or oral consent, permission, and assent. So the idea here is that you have to document written or oral consent, but the process of informed consent is generally, by most state law, and once again, I can't speak to all 50 states, but by most states, it is a verbal exchange between the practitioner and the client or patient. That exchange has to reflect that there's been a meeting of the minds and that the clinicians understand, the clinician believes that the client or patient understands what will happen and that there's an agreement that it can happen, that the patient has given consent for that. What I bring this up because some clinicians simply run clients and patients through a form. Let's say, here's a big fat packet, sign this thing and we're good to go. And they think that now they've handled informed consent. And if you look at state law, in most cases, that's not adequate. You need to have had an exchange eyeball to eyeball, if you will, or they're all written, but that there's an understanding about what's going to happen, including all of the risks and benefits. So if you're using a technology, the risk, if you're using email, for example, is that the email will get lost, or it'll get sent to the wrong person, or it may not be responded to in a timely fashion. So the client patient needs to understand that and agree that that's that's okay with them. If you're using video, there may be things that are unique to video. So you have to explain the risks and benefit of each technology you use. Now, one of the things that we have to do is provide adequate technology for our clients and patients. And there are a lot of questions that come up about this, but I am always quick to point to some pictures that I've taken at the ATA exhibit hall where people actually advertise that they're HIPAA compliant, or nowadays people understand it's not the companies that need to be HIPAA compliant. We need to be HIPAA compliant as the professionals. The clients, patients, or companies don't need to be HIPAA compliant. We need to be HIPAA compliant in our practices, and part of that practice is to use a HIPAA compatible service. So that means we can just look for companies that advertise that way. We've made it pretty easy at our institute for people to find those companies. We have a page, and I'll type it here for you. Let's see if I can get that pod to open up here. I was going to type it here. I can't see my chat. Can't get that to go. Sorry. It's telehealth.org/video. Pretty easy to remember. Telehealth.org/video. We've named 50 companies that we went to the website and found on their websites. They have the words either HIPAA compliant or HIPAA compatible. There it is. Okay, it's been changed. So it is www.telehealth.org. We did this because the demand is so high for people that they just want to know, well, what's an alternative to Skype? If I have to pay for something, what can I use? So we pull that together, and it's free. It's open to anybody who wants to go and take a look at it. We have also a column there that explains which ones give business associate agreements, because that makes it a whole lot easier for us to be compliant if we know that the company has agreed that they will accept any liability for their service going down or being hacked or anything being wrong with it. So when you get a company, a vendor of yours, to give you a business associate agreement, you're always in a better state than if you don't. So many companies give them. Some simply claim they're HIPAA compatible or HIPAA compliant. We don't vouch for everybody at any given moment in time. We did this review in July, so we link straight out to the companies. You can go check for yourself and see if you like that. And some companies actually put their pricing on their websites. We put that there too. So we've partnered with some companies. Some companies give us a referral fee off of that page. Just be aware of that. And also, they will give people who mention our name a bonus or a discount or something. So it might be to your advantage to mention if you see it there. If that's of use to you, feel free. So one of the things, the big questions that comes up is practicing over state lines. Is that okay? Well, it's pretty simple. I've heard some talks about this, and people go on, and I like to just simplify things for people because they tend to be overwhelmed by this stuff. And at least in my mind, there are two bodies you have to contact. One is your own licensing board, because some states have laws that say, like in California, they have this law. We're going to give you this license, Marlene. You can practice psychology in California, but you can't practice anywhere else if you're not licensed in those other areas. That is actually part of the California code. So it's what many states do, not all, but California certainly does it. Another law that is prevalent in many states is that you can't come in our state without being licensed in our state. So I call these the innies and the outies. Okay, so I can't go out of my state with my license the way my licensing law reads, and I can't go in another state because of the way the licensing law in many of those states reads. So those are the innies and the outies. If I want to practice over state lines, I have to do two things. I have to contact my licensing board and see if we're not in California. I already did in California, so I know California what mine is. I'm saying for you, if you want to practice in another state, contact your own licensing board or go to their website and read what the state law is. Once again, this is not rocket science. If you've got an advanced degree, you could probably read state law because it's pretty much in plain English. And then go to the state where you want to practice and read their state law about going in. I could save you that hassle and just tell you most of the time you're going to need to get licensed in that state or registered with that state, which is a process that could take 2 or 3 months, or maybe 6 months. It depends on the state. Some states will not let you register in their states either. But there are states that have penalties if you practice in their state without a license or without registering with them. And some of those states can be rather harsh. Vermont and Utah, for psychologists, there's a $5,000 penalty if you are caught practicing in their state without a license. Now, most of the time, you can practice. This is sort of like speeding, at least in my mind, it's like speeding. You can speed all you want, as long as nobody catches you. But if you get caught for speeding, then everything you've done related to driving will be under scrutiny. So, especially if you have an accident, everything you've done will definitely be under scrutiny. If there's a skid mark on the road, if your tires are not in good shape, if your brakes are not in good shape, if you're not registered, your car's not registered, if you don't have a driver's license, if your blood alcohol is high, if you're intoxicated with other drugs, everything about you and your vehicle will be under scrutiny. That is true about practicing over state lines as well. So my best advice is contact the state where you want to practice ahead of time, or have your clinicians do that, and then be vigilant with your mail and hope you get an answer back. If you can't get an answer back from them, call them up and get the name of the person you speak to on the phone and ask them how to do this. Some disciplines have some things in place to help us. Psychology has a group of regulatory folks that get together every year. On a regular basis. They had me come out and do their keynote a couple of years ago, so I know about them in particular. They are the ASPPB, the Association for State and Provincial Psychology Boards. They have a vehicle that they've created called the PCQ, I believe, and they just got funded, by the way, by HRSA because of how well advanced they are. They're getting $1 million over the next 3 years to look at licensure portability. So they'll be doing some tests and trying to do different things. But psychologists can register with ASPPB. They send their paperwork into ASPPB for their licensure to prove that, yes, they were supervised and they got all the hours and these supervisor letters and all that. And then ASPPB holds it through this PCQ program. I believe that's the acronym. And then they share that with other states if you want to get licensed in other states. So that's one of the ways in which this licensure issue is starting to get handled. There are other things. I know some of us at ATA are in a policy group, and we're bringing the senator from Massachusetts who chaired a committee and got a bill proposed through the House of Representatives in Massachusetts to do away with the licensing law as it is and invite practitioners from all the other states to come into Massachusetts to practice if they're licensed in any other state. Now, that is not law. Let me be really clear. He proposed this. It was not accepted. But his rationale in the proposal of this law, this bill, is something that we were very curious about, and so we invited him to come speak, and hopefully our proposal will be accepted and he'll be able to come and speak to us next year at the ATA. So there were a number of inroads. Different people are doing different things, and so I'm very active on this licensing issue, and so I really am trying to get as much done as I can. But right now, the law is you have to be licensed in a state, and the idea is that practitioners need to be licensed wherever the patient is. I know in the past we've always said the practitioner needs to be licensed where the patient resides, but now some states are coming out and saying the practitioner has to be licensed where the patient is when you treat them. So that college kid that you treated for 5 years before they went to college, who now is moved over the state lines, you may not be able to treat if the state law in that foreign state says you can't treat anybody like that unless you register, the other things I've said. So it always comes back to the same thing. Contact your own state, find out what you can do with your license, and then contact the state of whoever you'd like to treat and find out what they allow at this point in time. So that's that. So I've kind of covered, we need, in some states, actually, we need to be licensed in the state of residency of the patient. So some states, I mean, it's different by different states. So always go back to your own state. The thing that licensure implies that many people do not understand is that your malpractice coverage is dependent on your licensure. So if you practice over state lines without a license and something goes wrong, your malpractice carrier may very well say, hey, you were engaging in a criminal activity, and there's a little teeny clause in your policy that says we don't cover you if you're engaged in criminal activity. So while they may tell you they're going to cover you on the phone, they may not in real life cover you if you get in trouble for practicing over state lines. And I know this because I've actually called and asked. And at first I would say, hey, do you cover if somebody practices over, no, if I do online therapy? Oh yeah, sure, we cover that. And then when I dig further, because I know the law, and I said, wait a minute, if I'm licensed in California and I practice with someone in Idaho and he suicides and his family sues me, you're going to cover me, right? No, they're not going to cover me, because right there I've engaged in an illegal act, which is delivering services over state lines. So be very careful about that and check it out with your malpractice carrier. And if they tell you they do cover you, get it in writing, because I've encouraged my folks to do that for years now with malpractice carriers. And I've seen statements that literally read like this: sure, we'll cover you for everything you do that is comparable to what you do in your practice. So if you can imagine what the opposing counsel could do with that type of statement when you try to go collect from your insurance company, they can prove many ways that telepractice is different from an in-person practice. So be very careful about the words you get back from insurance company, and make sure that you've adequately defined what you want to do, and they repeat those words to you and they tell you, yes, we will cover you for the things that you said you're going to do. I'm going to be using the internet. I'll be working with this particular population. I will be servicing people in these areas, that kind of thing, so that you have it laid out very clearly about what your coverage is. Now, Skype. A couple words about Skype. The main thing about Skype, of course, is that it's free, and a lot of people have already downloaded it on their computers. So a lot of clinicians think that this is just the greatest thing since sliced bread. The problem with Skype, though, is that if you're on Skype, other people know you're on Skype that are linked to you through Skype, because when you come on to Skype, there's a little default mode that lets everybody in your system know that you just came on board. And it isn't only when you come on Skype, it's when you turn your computer on, or if you have Skype on your cell phone, when you turn your cell phone on, because the default mode for Skype is to always put their startup program in that tray, your startup tray, and part of that is that they will always notify by default everybody else that is connected to you through Skype. So it took me about a year of staring at my screen. This little orange thing would come on and say, Dr. So-and-so is online. Like, wow, isn't that interesting? How did I know that? I wouldn't, because it doesn't say Skype on it, or it didn't back then anyway. And now I think it does. But finally it dawned on me that that's a Skype message. So I went into my Skype default mode, and good enough, it defaults to letting everybody in the whole system know. And if I want, I could set it so that I could also know when all the people connected to me go off of their Skype. Now that's kind of scary if you're a clinician. I'm a clinician, practiced over 30 years. So I've had some clients that would not want to know when I'm jumping on and off the internet or doing anything in my personal life. So, that's up to you and your clinical judgment, but that makes Skype a social media platform as well as a video platform. And for that reason alone, I have to urge people to be very leery when they're using Skype. The fact that they don't allow for audit trails, that they won't come out and say that they are HIPAA compliant or compatible, whatever term they want to use, all of that, just I think it's a good reason to stay away. Other laws that we need to be mindful of. There are some platforms that do anonymous care. You might have seen them online. They're proliferating. Where they hire licensed mental health practitioners, and they will offer anonymous care to people. that are in need. And one of the problems there, of course, is how do we comply with our duty to report, our duty to warn? Some states require you to warn people if there's a homicide threat. Some states don't, but many states do. How do we comply with our regulations, our legal obligations to report abuse or suicide, homicide intent, depending on the state law? So it's tricky. It's important that we pay attention to these laws, because if we don't, who will? If we're the mandated reporters and we don't report elder abuse because we didn't manage to collect the name and the address of the person we're treating, we didn't do a proper intake, then it really falls on us. It's our responsibility. We've fallen down on the job. So that proper intake does involve everything a normal intake would involve. Now, I'm going to talk a little bit about different guidelines. We have over a dozen different guidelines that are in play for telemental health. Some groups say, oh, my professional association has not issued a guideline. You don't have to wait for yours. You can look at a number of, American Counseling Association had one that came out in 1999. I was actually in the guideline committee. They asked me to come over there and do that one, so I happen to know about that. They revised it in 2005. Their guideline for technology is quite evolved. Let's see, another very good one is the Australian Psychological Society. This happens to be my favorite one. They issued it in 2004. They also just revised it in 2011. Guidelines for providing psychological services and products on the internet. They go into a lot of information about text messaging, about your SIM card, that all your messages reside on your SIM card. You see, there are a lot of very useful guidelines. The Ohio one came out, Ohio Psychological Association came out with one in 2010. That's also very useful. And like I said earlier, the American Psychological Association will be having one that will be promulgated in 2013. But it's open for comment right now. You can actually download it off the website. And if you read it, I can guarantee you it's not going to be all that different when they modify it and promulgate it in I think it'll be February of next year is what I've heard. Another big issue with those guidelines, though, is, and most guidelines talk about this, is boundaries of competence. We have to be competent along the lines of the typical thing, racial, linguistic, gender, religious, cultural diversity. We have to be aware of that. We also have to be very well versed in the technologies that we use. We have to understand the technology we're using and what can go wrong with it, like Skype. The fact that Skype shows that little message, if we don't know that, then we're the ones that are remiss. We need to understand the technology before we invite our patients and our clients to come use it with us. Now, I'm drawing some distinctions here between what's the online norm and the general standard of care according to the literature. What we're seeing for telemental health. What the online norm is mostly email. We see many clinicians, and you can find this by go to Google. My best friend is Google. So look up online therapy, look up online counseling, look up online counseling with double L's. I did that search just for those 3 items about a week ago, and I found 1.9 million websites worldwide that had those terms, and I'm putting those terms in quotes, okay? So I'm really narrowing down. Online therapy, online counseling, single L, online counseling, double L, which is the British spelling. 1.9 million websites. How do we trust that all of those websites, all of those people are delivering good quality care? People are making up a lot of rules. They have a lot of anonymous sites. They try to avoid responsibility with website disclaimers. Oh, if you're suicidal, then we can't service you. Well, most mental health people that are going to be suicidal are not likely to be mindful of when that will hit them. So it's kind of tough for them to weed themselves out. Actually, many clinicians report, and I'm sure the literature is very clear about this, many people do start reporting suicide ideation the first few weeks of therapy. They have someone to support them, and now they kind of let go and they get into those feelings. And so it's a common occurrence to have somebody tell you they're suicidal a few weeks in to treatment, and they don't really recognize that the first time they came through the door. So, it's a challenge. Also, they don't have clear mandates for reporting, for mandated reporting. They don't have clear guidelines for that online. A lot of times they don't have contact with our treating clinicians. We need to do that. They don't authenticate the consumer or the professional. You could have anybody setting up a website saying they're Dr. So-and-so and got a degree from the Sorbonne. They're licensed in 3 different states. How would anybody know? There's really no way to authenticate folks that way. That's easy. That is on par with what we've done in traditional telemental health, which is to have somebody come into a remote clinic and then be assessed, do an intake, have all their license, their insurance card examined, the general intake form. Oftentimes they'll have hands-on vitals taken by a nurse, and then they'll get referred out to a clinician that might be in an urban setting. Some of you that are here with the Resource Center will know that's a classic hub and spoke model. That's what the backbone of telemental health research has involved, is an urban clinic, an urban hospital that gets connected to a rural area. And in that rural area, a lot of times you'll have champions. You'll have people that will not only help do the intake, the administrative staff and maybe a nursing staff, but you'll have champions in the community that will do the liaison work with the school if it involves a child, or with EMTs if there's an emergency, something needs to happen, and whatever the local hospital is, or somebody's there to make sure things happen. A lot of times when people practice online, they don't know about that, and they kind of skip that whole step. And so there's no real emergency backup procedures. Folks don't understand the clinical processes involved with how you give a referral in your own city. That's one thing, but what about when you give a referral for some type of wellness check in a remote area? If you dial 911 to get that hotline into the police department, you're going to get your own police department. You're not going to get the 911 in that area. If you try to dial into that area and you say you're a doctor, they may or may not believe you. You could be anybody saying you're a doctor. They have to somehow authenticate you, figure out who you are, make sure this is a legitimate call. So it really requires some type of contact with the remote areas before you go there, and let folks know that you want to service people in their community, and that you are legitimate. Here's your license, and so give them fax that information over, whatever you want to do, scan it and send it over there, so that there is that net that is in place if somebody does get to be problematic, starts decompensating, so that we can actually do our job and hold them together. So there's a very little research on this. I know David Luxton, some of his colleagues up at T2 in Washington are doing research on unsupervised settings and safety issues there, but the research is just starting, and so we all need to be mindful of that and be careful about it. So another thing is to be using research-based protocols. When we're practicing with people online, it's really not the same as what we're doing in our office. It can be akin, but we have to go back to the research literature and look at what is there for us. So if we're dealing with pregnant teens, for example, go look up the telemedicine and the telemental health research and see what other folks have done to service them and approximate those services. Don't just be making it up as you go. Also, when you're choosing clients and patients, study the evidence base, study that research. The truth is, almost everybody with mental health diagnoses have been serviced in one way or another. Obviously, people who are flagrantly psychotic need a little more support here. So doing an intake on the internet with someone in that state, it's not advised. And if you look at the literature, that's not what you see in the literature either. But a lot of times people do go inpatient, they do get care, follow-up is through video conferencing, and it's quite effective with them. So there's a ton of studies about that. That's been going on with very severely disordered patients for a long time. To consider compliance problems too. If someone's really going to be adhering to the treatment regimen, what's in place for them? That's where that champion in that community can be very helpful. Also, documenting what you're doing. Document not only what you normally document in an in-person practice, but then you need to document what happened with the technology. Did it break apart? Was there an outage in the call? You have to document the time that the outage happened, what you were talking about. You have to go a few extra steps in your documentation. Also, in terms of your assessment, just look at the ethics code for whatever discipline you're in and see if it's physically possible for you to do what is required to do good clinical care if you want to do it remotely. Also, what we encourage at our institute when we're training clinicians is to contract for short, protocol-driven treatment. Maybe a short CBT model is helpful. Or for what I do is I do a stop smoking intervention. It's a 6-session intervention. After 6 sessions, if people are showing up, if they're responsible, if they're on time, if they're doing good solid work, then I'll treat them for some of the underlying disorders that often come up with smokers. A lot of times smokers have an underlying depression or anxiety disorder that need to be treated. So then I will engage them, but I only start with that short protocol-driven model at first for smoking cessation. If they can't cut it, then we go into some of the deeper level work, but only after I've already screened them out. And I always do my intakes in person. So also authenticate and set ground rules at every session. Enforce your boundaries about your office. Some clinicians get overwhelmed with all this electronic media coming at them, people texting them, people popping into their video world, all of this. Have your office hours. Don't overextend yourself. That's all I can suggest. Just be reasonable about when you're available. Give people backup for when you're not available, and then have a regular life. Also, you need to evaluate things at regular intervals. Is this intervention helpful for them? The APA guidelines that are open for comment right now require the documentation of that particular assessment at regular intervals. And then, of course, have a backup emergency plan where you know the resources in that person's community if you want to refer to them. There are also a number of very good guidelines that are at the American Telemedicine Association. That 209 video conferencing guideline, here again, they say patient site assessment should be undertaken, including obtaining information from local regulations. So I'm just supporting what I'm telling you here. There's a lot of evidence that we need to have good, solid understanding of what's happening for emergencies in these remote areas. Also, have your own policy in your office about what you're going to do to involve other people. Have guidelines determining at what point other staff and resources should be recruited to help manage emergencies. Have your informed consent document. That really is the document that's going to protect you the most if anything goes wrong. So be very clear what's happening with people and make sure that they agree to everything. Once again, that bibliography that we have, if you're looking for references, is telehealth.org/bibliography, and that video platform that I mentioned for the 50 alternatives is /video. If you want to ask questions, I'm going to keep talking. I have a few extra slides, but please feel free to ask your questions in the Q&A box here, and then I'll be happy to answer you. But otherwise, I'll keep talking because I always have a lot of information. I do a 7-hour training on this in person, and it tends to still run over. So there's a lot to cover. No, I can't see them. All right. Yeah, well, see, that depends on the discipline of the practitioner. So if you're talking about physicians, that would be a matter of state law as to what the requirements are. It's complicated, Adrian, because we have so many disciplines in mental health. We have psychiatry, psychology, counseling, social work. A lot of times counseling and social workers have the same law, but psychology and psychiatry have different laws. And so I can't be an expert in 50 states and then all 50 and all these 3 different areas for each of those 50 states. I really think it falls on the clinician to have learned what the state law is of the state that they're practicing in, and then not engage a patient if they don't understand the law in that foreign state. Because, ignorance is not a defense in the face of the law. So if you say, oh, gee, I'm so sorry, I had this emergency consult, but I didn't understand the state law, not a defense. If something really goes wrong there, and that family, say the person suicides, family sues you, you're responsible to know that law. So that's where we really need to start looking at the law more carefully. Yeah. That's a really good question because What's happening with electronic health records is that they are requiring meaningful use. The second stage of meaningful use requires that when you let that patient go, they have a summary of the session in hand and recommendations written out. So that's going to change how we practice. Now, many people are not using electronic health records yet, but we will, because if we don't by the year 2014 or 16, depending on Medicare and Medicaid, our already low Medicare and Medicaid payments will be docked. And so we'll get a percentage taken off the top of our payments. So many groups are getting the electronic health record in place, and that is part of the second stage of that meaningful use. So how we talk with our people when we take our notes, the terms we use. I was chatting with a fellow who does use electronic health record in his community clinic. He was a CEO, and he explained to us that many of the docs have been pretty lax about the terms they use. Morbidly obese, they use terms like that in the patient record. And then when they have to give the note to the patient for meaningful use, the patient looks at that and says, "What are you talking about, morbidly obese? I'm just a little chunky." And they really get upset about that being in the medical record. So they've actually had an in-service in his place to teach the docs how to use more culturally sensitive terms. So it was right across the board. It wasn't just about being obese. It was right across the board. The language being used was offensive to the patients. So this whole change of electronic health records is going to change the requirements for documentation. If you're not using electronic health records, then whatever system you have in play, I'd encourage you to start thinking about the fact that we're all going in that direction. And your docs may need to be trained. But you touched on a question. I'm not sure if you were really meaning how do you get started with a practice. One of the strategies I've seen the most successful is to have some meetings with your referral sources, and that is to invite community members that would normally be referring to your docs, invite them in and have a talk about it. I know I go out and talk to groups about that, just talk about the literature and explain why this is effective. Or you can have one of your docs who may have read up on things or trained in this area cite some of the literature about what the efficacy rates are, why people are saying it's effective, just so that the normal instinct to say, no, we don't want to do that, those barriers can come down, because the biggest problem we're having is practitioner adoption. Patients are not having a problem with most of this, because their satisfaction rates are usually 80–85%. It's the docs that are saying no, which means the referring docs will be saying no. And to recruit them and help them have some decision making in what you're doing, it's kind of like infiltrate the ranks of the referring to you, and they will start to understand this, and maybe they'll start looking for this literature a little bit more, and over a few years' time, you will have a strong, robust referral network. Some clinics that just start cold and announce to the world that they've got this service don't end up being very successful. So I see Martha says a few things. Oh, that was just, okay, notes to the group. Any other Q&A, Bob? Yes, let me just go through these slides really fast, because I think they're important, and we do have a few minutes left. Okay, yeah, thanks. What we advocate in our institute for some groups that just have a regular practice or a regular clinic, a small hospital, is the migration model. Start with current clients that you understand. Select those that are reliable, have good support systems, they have a good family system, maybe a good church system, whatever, but that there's a net there for them, and with whom you have a good working relationship. And then think about their diagnosis. If they're flavorally psychotic, again, not a good choice. If they are perpetrators, child molesters, then not a good choice. Think about what you're doing, what the dangers are there, and then take some time to prepare them. There's a whole education module that we have about how you educate your client, to your patient, to deal with all of this, because a lot of them are already struggling. They're having an emotional crisis. We don't want to overwhelm them. We have to kind of ease them into this and show them the ropes. Plan an in-person session at regular intervals. That's what, if you have an in-person practice and you're migrating, then you can say, why don't you come on in every third, fourth, fifth, sixth, whatever you think is reasonable. But start training them to the fact that they can come back in and have a regular session in which you can say, so how is that really working out for you? Do you like that? Do you not? Should we keep doing it? But do it in session with people. I think that's kind of a more moderate approach to let's just go wild and do everything we want online. And then don't work through other people. It's very easy to get seduced into everything is automated. Oh, we've got secretaries. My secretary set that appointment up with you, or we'll be only working with the online scheduling program. There's a lot of, especially in mental health, there's a lot of fine interactions that happen there. When you pick up the phone and you hear the person's voice, you know something's really wrong, and you need to schedule them today, as opposed to them just scheduling, 3 weeks from now. So there are some things there that a live staff have been able to do. So make sure that you get some type of message from your client directly. There's very traditional models that have been extremely successful for telemental health. And I'm just going to run through them very quickly. Nursing homes, very strong model. There are companies that are going around the country wiring up nursing homes. Why? Because there are three things for us clinicians. The nursing home provides the clients. If you get a contract with a nursing home, they bring the clients to you through your video interface. The intake is done with a nurse in the room. So there's a licensed person in the room or an attending physician. Most nursing homes have attending physicians. So there's somebody there that is a responsible professional that can assist you with that intake if you're not there in the flesh yourself. The other thing is, a lot of times they'll do billing for you. A lot of clinicians don't like doing billing. That if you can get some group to do billing for you, bill Medicare, Medicaid, great. That takes it off of you. And the other thing is there's that attending physician. If there's an emergency, you make a note in the chart, you have your evening. You don't have to be panicking about how am I going to get the cops out there because they're in a residential facility. That's true of schools as well. A lot of schools need, although Medicare, Medicaid payment is not as readily available unless you're dealing with children who have a severe disorder, but many schools have nurses and you can get the same thing. You can get, if you want to contract with schools, they can start supplying you with ready supply of clients, patients. They do have a professional on staff, and they're already networked in their community to help you know how to plug into a PERT team, an EMT team, or somebody to help you in some type of crisis. Some, especially hospitals, have this. A lot of children's hospitals may want to engage your services for mental health care. Rural hospitals, we interviewed somebody, we actually have a webinar, one of the gals that we're working with has a webinar on how to do rural hospital work, correctional facilities, home health, military, VA. One of the things that I wanted to let you know about is that we're having a summit, and it's starting next week. We have a very low-cost summit. It's the launch for our website. We have 500 people just about right now, 500 people studying with us, but we haven't done our launch yet, so we're going to have a formal launch. It's an entire conference that we set up. We have 10 speakers, 10 of the top speakers in the country. We've audio recorded them. We have transcripts. We have a number of different bonus files for people to come on board and listen to other things, including that one about the rural hospitals. And what I want to let you know is if you send people our way, we're happy to give them a $30 discount coupon because they come from you, or if you want to come and attend. That is, the address for that is www.summit.telehealth.org/register, and you'll see the outstanding lineup of people we have. And my rationale for this, by the way, is this summit is my pilot project. It's my proof of concept that we can deliver conferences on the internet. And for example, what we're doing for Monday's conferences, we're making all the transcripts available today. So can you imagine going to a conference where you can physically look at the transcript in a PDF file or on your Kindle, which this will be on the Kindle, 4 days ahead of time, and that you can actually see what will be said there so you can formulate your questions and know who you want to ask what up. I mean, this is a new way to do conferences, so we're very excited about it. I want to give you the URL, summit.telehealth.org/register. And once again, if you want to come in for a discount or send some of your colleagues in, just tell them to type into our shopping cart, Summit, all caps, Summit 2012, and we'll be happy to let them in. The ticket price for that is $197, so $30 off is $167. If people want all of the whole enchilada, it'll be $220. They get 10 units, 10 CE units, or 8 CMEs. So it's a pretty good thing all the way around for everybody. So with that, I'm finished. Thank you, Bob. Okay. Oh no, they're quite successful. Actually, at our summit, we have Evelyn Nelson, who's one of the people that came up with the telepsychology, no, the telemental health guidelines for the ATA in 2009. She's one of the authors of that. She was actually the co-chair of that. She does an hour talking about pediatric telemental health. She's a director of research over at, she just got promoted. She's the director of research over at University of Kansas. And it's and she explains their entire model, what she does over there, and why it is so successful. So there, the body of literature is growing. It's not as robust in pediatric psychology or psychiatry as it is for adults. Obviously, we just haven't had that much of it, but what we're seeing is it's quite successful. And one of the reasons that she explains is exactly what I mentioned earlier, that if you catch people early, if you catch children early in their trajectory of when they're starting to get in trouble at school, when they're starting to be in trouble in their neighborhoods, then there's probably something you can do much earlier on than if you wait until they end up getting arrested for something. Yes. You're welcome. My pleasure. Thank you.